Prevention and treatment of insomnia. Prevention and treatment of insomnia may require a combination of cognitive behavioral therapy, medications, and lifestyle changes. Among lifestyle practices, going to sleep and waking up at the same time each day can create a steady pattern which may help to prevent insomnia. Avoidance of vigorous exercise and caffeinated drinks a few hours before going to sleep is recommended, while exercise earlier in the day may be beneficial. Other practices to improve sleep hygiene may include avoiding or limiting naps, treating pain at bedtime, avoiding large meals, beverages, alcohol, and nicotine before bedtime, finding soothing ways to relax and to sleep, including use of white noise, making the bedroom suitable for sleep by keeping it dark, cool, and free of devices such as clocks, cell phones, or televisions. Maintain regular exercise. Try relaxing activities before sleeping. It is recommended to rule out medical and psychological causes before deciding on the treatment for insomnia. Cognitive behavioral therapy has been found to be effective for chronic insomnia. The beneficial effects, in contrast to those produced by medications, may last well beyond the stopping of therapy. Medications have been used mainly to reduce symptoms in insomnia of short duration. Their role in the management of chronic insomnia remains unclear. Several different types of medications may be used. Many doctors do not recommend relying on prescription sleeping pills for long-term use. It is also important to identify and treat other medical conditions that may be contributing to insomnia, such as depression, breathing problems, and chronic pain. As of 2022, many people with insomnia were reported as not receiving overall sufficient sleep or treatment for insomnia. Non-medication-based strategies have comparable efficacy to hypnotic medication for insomnia, and they may have longer-lasting effects. Hypnotic medication is only recommended for short-term use because dependence with rebound withdrawal effects upon discontinuation or tolerance can develop. Non-medication-based strategies provide long-lasting improvements to insomnia and are recommended as a first-line and long-term strategy of management. Behavioral sleep medicine offers non-medication strategies to address chronic insomnia, including sleep hygiene, stimulus control, behavioral interventions, sleep restriction therapy, paradoxical intention, patient education, and relaxation therapy. Some examples are keeping a journal, restricting the time spent awake in bed, practicing relaxation techniques, and maintaining a regular sleep schedule and a wake-up time. Behavioral therapy can assist a patient in developing new sleep behaviors to improve sleep quality and consolidation. Behavioral therapy may include learning healthy sleep habits to promote sleep relaxation, undergoing light therapy to help with worry reduction strategies, and regulating the circadian clock. Music may improve insomnia in adults. See Music and Sleep. EEG biofeedback has demonstrated effectiveness in the treatment of insomnia with improvements in duration as well as quality of sleep. Self-help therapy, defined as a psychological therapy that can be worked through on one's own, may improve sleep quality for adults with insomnia to a small or moderate degree. Stimulus control therapy is a treatment for patients who have conditioned themselves to associate the bed, or sleep in general, with a negative response. As stimulus control therapy involves taking steps to control the sleep environment, it is sometimes referred interchangeably with the concept of sleep hygiene. Examples of such environmental modifications include using the bed for sleep and sex only, not for activities such as reading or watching television. Waking up at the same time every morning, including on weekends. Going to bed only when sleepy and when there is a high likelihood that sleep will occur. Leaving the bed and beginning an activity in another location if sleep does not occur in a reasonably brief period of time after getting into bed, commonly 20 minutes. Reducing the subjective effort and energy expended trying to fall asleep. Avoiding exposure to bright light during nighttime hours and eliminating daytime naps. A component of stimulus control therapy is sleep restriction, a technique that aims to match the time spent in bed with actual time spent asleep. This technique involves maintaining a strict sleep-wake schedule, sleeping only at certain times of the day and for specific amounts of time to induce mild sleep deprivation. Complete treatment usually lasts up to 3 weeks and involves making oneself sleep for only a minimum amount of time that they are actually capable of on average, and then, if capable, i.e. when sleep efficiency improves, slowly increasing this amount, 15-minute, by going to bed earlier as the body attempts to reset its internal sleep clock. Bright light therapy may be effective for insomnia. Paradoxical intention is a cognitive reframing technique where the insomniac, instead of attempting to fall asleep at night, makes every effort to stay awake, i.e. essentially stops trying to fall asleep. One theory that may explain the effectiveness of this method is that by not voluntarily making oneself go to sleep, it relieves the performance anxiety that arises from the need or requirement to fall asleep, which is meant to be a passive act. This technique has been shown to reduce sleep effort and performance anxiety, and also lower subjective assessment of sleep onset latency and overestimation of the sleep deficit, a quality found in many insomniacs. Sleep hygiene is a common term for all of the behaviors which relate to the promotion of good sleep. They include habits which provide a good foundation for sleep and help to prevent insomnia. However, sleep hygiene alone may not be adequate to address chronic insomnia. Sleep hygiene recommendations are typically included as one component of cognitive behavioral therapy for insomnia, CBTI. Recommendations include reducing caffeine, nicotine, and alcohol consumption, maximizing the regularity and efficiency of sleep episodes, minimizing medication usage and daytime napping, the promotion of regular exercise, and the facilitation of a positive sleep environment. The creation of a positive sleep environment may also be helpful in reducing the symptoms of insomnia. On the other hand, a systematic review by the ASM concluded that clinicians should not prescribe sleep hygiene for insomnia due to the evidence of absence of its efficacy and potential delaying of adequate treatment, recommending instead that effective therapies such as CBTI should be preferred. Main article: Cognitive Behavioral Therapy for Insomnia. There is some evidence that cognitive behavioral therapy for insomnia, CBTI, is superior in the long term to benzodiazepines and the non-benzodiazepine in the treatment and management of insomnia. In this therapy, patients are taught improved sleep habits and relieved of counterproductive assumptions about sleep. Common misconceptions and expectations that can be modified include frowny face citation needed, unrealistic sleep expectations, misconceptions about insomnia causes, amplifying the consequences of insomnia, performance anxiety after trying for so long to have a good night's sleep by controlling the sleep process. Numerous studies have reported positive outcomes of combining cognitive behavioral therapy for insomnia treatment with treatments such as stimulus control and the relaxation therapies. Hypnotic medications are equally effective in the short-term treatment of insomnia, but their effects wear off over time due to tolerance. The effects of CBTI have sustained and lasting effects on treating insomnia long after therapy has been discontinued. The addition of hypnotic medications with CBTI adds no benefit in insomnia. The long-lasting benefits of a course of CBTI show superiority over pharmacological hypnotic drugs. Even in the short term, when compared to short-term hypnotic medications such as zolpidem, CBTI still shows significant superiority. Thus, CBTI is recommended as a first-line treatment for insomnia. Common forms of CBTI treatments include stimulus control therapy, sleep restriction, sleep hygiene, improved sleeping environments, relaxation training, paradoxical intention, and biofeedback. CBT is the well-accepted form of therapy for insomnia since it has no known adverse effects, whereas taking medications to alleviate insomnia symptoms have been shown to have adverse side effects. Nevertheless, the downside of CBT is that it may take a lot of time and motivation. Treatments based on the principles of acceptance and commitment therapy, ACT, and metacognition have emerged as alternative approaches to treating insomnia. ACT rejects the idea that behavioral changes can help insomniacs achieve better sleep, since they require sleep efforts, actions which create more struggle and arouse the nervous system, leading to hyperarousal. The ACT approach posits that acceptance of the negative feelings associated with insomnia can, in time, create the right conditions for sleep. Mindfulness practice is a key feature of this approach. Although mindfulness is not practiced to induce sleep, this in itself is a sleep effort to be avoided, but rather as a longer-term activity to help calm the nervous system and create the internal conditions from which sleep can emerge. A key distinction between CBTI and ACT lies in the divergent approaches to time spent awake in bed. Proponents of CBTI advocate minimizing time spent awake in bed, on the basis that this creates cognitive association between being in bed and wakefulness. The ACT approach proposes that avoiding time in bed may increase the pressure to sleep and arouse the nervous system further. Research has shown that ACT has a significant effect on primary and comorbid insomnia and sleep quality, and can be used as an appropriate treatment method to control and improve insomnia. Despite the therapeutic effectiveness and proven success of CBT, treatment availability is significantly limited by a lack of trained clinicians, poor geographical distribution of knowledgeable professionals, and expense. One way to potentially overcome these barriers is to use the internet to deliver treatment, making this effective intervention more accessible and less costly. The internet has already become a critical source of healthcare and medical information. Although the vast majority of health websites provide general information, there is growing research literature on the development and evaluation of internet interventions. These online programs are typically behaviorally based treatments that have been operationalized and transformed for delivery via the internet. They are usually highly structured, automated, or human-supported, based on effective face-to-face treatment, personalized to the user, interactive, enhanced by graphics, animations, audio, and possibly video, and tailored to provide follow-up and feedback. There is good evidence for the use of computer-based CBT for insomnia.